Morning, everyone. Welcome to Pediatric Grand Rounds. Thank you for joining us this morning. Our speaker today is Dr. Richard Cordle from the Department of Pediatric Gastroenterology. He's Associate Professor of Pediatrics at the Virginia Tech Carilion School of Medicine. Dr. Cordle grew up in Richmond, and after completing his undergraduate at University of Virginia in Charlottesville, went to Washington University in St. Louis. He returned there for fellowship at St. Louis Children's after a 3-year residency at Wilford Hall Medical Center in the United States Air Force in San Antonio, Texas. After fellowship, he returned to the Air Force in San Antonio and served on staff there in the Pediatric Gastroenterology Division with the San Antonio Military Pediatric Center. He joined Carilion in 2002, and when not spending time finishing charts, he's focused on his family, both near and far, in Nashville, Miami, and Wilmington. Please join me in welcoming Dr. Richard Cordle.
So I've chosen this topic for myself so I could learn some stuff and know how to approach these patients. So hopefully you'll find it interesting. And these are all gallstones, aren't they beautiful? I'm being disclosed. So today I'm just going to try to talk a little bit about pathogenesis of gallstones and gallbladder disease. We're going to talk about risk factors for some of these groups. I'm going to talk about some specific issues, things like asymptomatic gallstones, acalculous, cholecystitis, biliary dyskinesia, and then we're going to spend a few moments on odd malformations. So as you're sitting here thinking about gallbladder disease, you might be saying, isn't gallbladder disease mostly seen in adults? And then you might be, and I know this isn't politically correct, but you might be thinking the 4 F's. Remember? Fat, female, fertile, 40 for children. And in fact, you're right. Gallbladder disease is an adult problem. So the National Health and Nutrition Examination Survey in 1999 showed that the prevalence of gallbladder disease in adults is extremely high. 20 million people, 14 million women, and then 6 million men. And as you age, you are at increased risk. And these are some graphs from that article. So you see in this top left corner that this is men. And you can see age on the x-axis and then percent as it goes up. You can see that with age, there's a sharp increase so that hopefully I won't have an attack before I leave. So over here you have women, and you can see that I've drawn this line to correlate men to women. You can see that women exceed men by quite some degree, as well as a 2-fold increase in prevalence. And then also that increased BMI is also a risk factor for having gallstone disease in adults. So how does this apply to children? Well, there's still a relevance to us. Now, many years ago, the prevalence in children in an Italian cohort was found to be 0.13%, so quite low compared to the adult. And then in 2005, another series out of India with a much larger population showed that was somewhat higher, 0.3% of the population. Then this is a series of 493 children from Germany. And what they did was they looked at a particular population with increased BMI. Now these, and what you notice is an interesting fact, an interesting trend. What you see here is in the younger ages, these zeros. GD stands for gall. It's not a curse word. It stands for no gallbladder disease. So you can see that the lower ages, no one was testing positive. There was no hemolytic disease in this population. These are all cholesterol gallstones. And these are all people, majority of the people had BMI above 25. And what you see here is that 10 people out of this 493 were positive or had gallbladder disease. So that's about 2%. Now, if we start to extrapolate that to the entire population, this graph is from the NIDDK estimate of obesity in American population. This is 2017 data. And what you see is about 25% of the population is has a BMI above 25. So if we multiply that times our 2% of obesity, we get about 0.5% of the population of children. So an increased incidence compared to that group in India. And this is extrapolated to the whole population. So it's not just an adult problem. It's a problem that's also attacking kids. And if you think about it, you've seen these people come onto the ward, and it's usually something that we're not really boned up on. So hopefully this talk will help you with that. So we'll start off with the basics. This is a picture of the anatomy with the liver kind of pulled back, sort of the med student view. As you pull back on the liver and hold your retractor, this is what was seen. So this is the liver right here, and the liver has making bile and bilirubin secreted through into the canaliculi and then into these bile ducts. So this is the left and right bile duct. It's drained and then it's held in the gallbladder. As we eat our Five Guys dinner, the message from cholecystokinin comes from the stomach and comes over to the gallbladder, and it says squeeze. And so it squeezes that out, comes through the cystic duct and out. And that bile is useful in helping us to digest that fatty food. One more thing to note is that this, you can see the vasculature here. This is the cystic artery, and this is an end artery, which is useful to know because in states of shock or sepsis, the blood flow to the gallbladder can be compromised, even during surgery, and that's what leads to things such as acalculous cholecystitis. So that ischemia can be a problem. This little neck here can also be a problem. This is where the stones often like to lodge and cause contraction, stasis of bile flow, and then inflammation develops in the body of the gallbladder. So this will be our roadmap as we go forward. And now we're going to go through, we've seen what the normal looks like. Now we're going to go through things that you may never see. Now, at the absence of gallbladder, we do see, especially with patients who have extrahepatic biliary atresia. So when they do the ultrasound and they don't see that there is a gallbladder there, our antennae are up that maybe this is maybe biliary atresia. CF patients have scarred down, difficult to see gallbladders, and it might even lead to atrophy and not being able to be seen on an ultrasound. Usually you can live without your gallbladder, so there's usually no symptoms. There are actually some animals that are made without a gallbladder. You can have a double or a bifid gallbladder. I have a patient with this that threw us off when he was born. You can have a malposition with it lying on the left side, underneath the left lobe, or it could be pendulous and kind of swinging free, so to speak. These people are more prone to have gallstones from problems. If you have a septated or walls within the gallbladder, that's going to make you more prone to have acalculous cholecystitis. This is a neat thing. So this is a Phrygian cap you might hear about on a ultrasound report. So this is the, over here, this is what it's demonstrating. So this right here is our hepatic ducts, right and left. And then this is the gallbladder here. So it has like this little hat, so to speak. This is what it looks like on an ultrasound. Now this is probably the least important thing I'm going to talk about today, but it's the thing you're going to remember. So because you're like, wow, Phrygian cap, it has no clinical significance. It's just an oddity. But when I leave here today, you're going to think Phrygian cap. So here is Smurfette. She's showing you what a Phrygian cap looks like. This is a Steeler Smurf or something like that. Anyway, so this child, this isn't a child actually, this is an adult. So this person has not, this isn't a foreign body lecture. So the person hasn't swallowed whatever this is. They also have a Miralax deficiency, as you can see. This is a porcelain gallbladder, which is it's calcification of the entire wall, the mural lining of the gallbladder. And it's an important thing to see. There's only been a handful of cases in children. 2019 represented the 4th case. I think there may be a few more reported. This is important. You need to take this gallbladder out. It has a higher cancer risk going forward. Adenomyomatosis is another thing seen. Actually, we've had a case here not so long ago. A patient showed up and swore that it was her gallbladder. You know these patients. My mom had it. Her mom, we're a gallbladder family. And so regardless of everything we did, we couldn't tell her that it wasn't, she just had irritable bowel. So an MRI was done and an ultrasound was done, and this is sort of what we found, were these little diverticula that are in the lining of the intestine. These are like little sinuses, and they can get inflamed, they can cause pain. This person on our floor did get her cholecystectomy, but sometimes they're just random findings that we have. So if the patient's asymptomatic, you don't have to do anything about it. A little bit more prevalent than a Phrygian cat, maybe a little more prevalent than a porcelain gallbladder. And then there are gallbladder polyps. I don't know if Dr. Stone has seen any of these, but I've seen 1 or 2 patients with gallbladder polyps. And we kind of have just told them this is benign. And for the most part, that is good information. So here's an ultrasound showing you these polyps here. Does my mouse show up there? Okay, good. So this can be associated with other disorders, like if you have multiple polyps, you might see this with other polypoid disorders like Poids-Jager's, some pancreatico-biliary anomalies where the bile and the pancreatic ducts fuse at different points. Metachromatic leukodystrophy can also have more gallbladder polyps. You can usually just watch these patients unless they're having tons of symptoms. And then one recommendation from one paper was, depending on the size of the polyps or the number, you might follow them more regularly. So just a small one, you can maybe repeat your ultrasound in a year to make sure you're not seeing more of them. And then that interval decreases as the size goes up. And then if they're huge boys, you might want to send them to have the gallbladder taken out. So something you might see actually on an ultrasound report. So the remainder of the talk is going to be on this. So calculus and acalculous cholecystitis. So what we're going to talk about is pigmented stones, which is coming from calcium bilirubinate. That's what gives it its pigment. So there's black pigmented stones and brown pigmented stones, which are probably best described as mixed between pigment and cholesterol. There's calcium carbonate stones and cholesterol stones. We're going to talk about those probably ad nauseum. And then acalculous cholecystitis, because that's what we see a lot of, actually. All right, so what does it require to get pigmented stones in your gallbladder? So first you have to have increased excretion of unconjugated bilirubin. And unconjugated bilirubin is very prone to precipitate with calcium and make crystals and come in solution. You have to have increased calcium, stasis or poor motility of the gallbladder, and mucin or mucus in the wall of the gallbladder, which helps with precipitation. So as we talk about black stones, they have a large amount of calcium and phosphate and carbonate, which makes them visible underneath x-rays. So about half you can actually see with plain film. And then when they form a polymer, they will come out of solution. So this is an important roadmap for us, and good to know. If you ever have a patient with Gilbert's, it's good to think this through, because I often will draw this for them to kind of help them to think what's going on. So what happens is, as you know, our red cells have a lifespan, about 120 days, and then it's filtered through the spleen, the oil filter, so to speak, of the human body. And then the broken down red cells release hemoglobin, which then is converted into biliverdin and then into unconjugated bilirubin. This is bound to albumin and brought to the liver. In the liver, it goes through a conjugation process, the bilirubin does, with UDP glucuronal transferase. Once it's conjugated, then it gets secreted and then held in the gallbladder. Then it's released. Once in the GI tract, then bacteria will actually deconjugate it. There's an enzyme that deconjugates it, and about a quarter or 20% will be reabsorbed in the colon and then come back to the liver. Some gets peed off. And then the remainder of this goes out in our stool, and as I'm sure you are delighted to know, is what gives the poop its color. So conditions that predispose us to black pigmented stones, stool's always on my mind. So is hematology. So let's go back to this. So if we think about this. What could go wrong that would make me have more unconjugated bilirubin? So if you have more coming from this direction, so more breaking down, or if you had a problem here with this enzyme, you would have more unconjugated bilirubin slipping through. About 1% of our bile has unconjugated bilirubin in it. And so the more that gets enriched, the more chance that you're going to have a stone. So sickle cell disease is the prototype of hemolysis that leads to black pigmented stones. And this is increased with age. So as you can see, that by the time you are graduating from college, your risk for stones is about half. So in the majority of these, and these are most patients who have sickle cell disease and stones, if they become symptomatic, are prone to having complications. So the recommendation is that even though it could be asymptomatic, the recommendation is to take these out. Here's a study that was looking at this question of should we take them out electively or wait till they start to have symptoms. In a series of more than 1,000 patients, these are adults who had sickle cell disease compared to controls who had CCK, which is my abbreviation for cholecystectomy. So then they had a longer length of stay, higher cost, and increased complications. And the difference, if they were an acute surgical procedure, was much higher. Thus, elective surgery is preferred ones, and some have recommended even screening patients. Other hemolysis syndromes are also involved, but less commonly. Only about 5% of patients with hereditary spherocytosis go on to develop cholelithiasis. So other conditions that favor black pigmented stones are ileal resections and TPN. So ileal resections, that's where we reabsorb bile salts. It's the only place where bile salts are absorbed in the GI tract. So if you've had necrotizing enterocolitis and lost your ileum, or if you have Crohn's disease and it's not functioning, you could have less bile salt reabsorption. Those bile salts are poured into your colon and they immerse the bilirubin, favoring the deconjugation process and favoring reabsorption of unconjugated bilirubin. So that's how that plays a role. Biliary resection can also lead to cholesterol stones, and we'll come back to that as well. TPN also decreases the function of the gallbladder, so there's less squeeze, and so there's more stasis involved with that. The longer that you're on TPN, the more chance that you you're going to have stones. Within a few weeks, stones have been seen once someone has started on TPN. This is what I said. So, with TPN, you can see that reverse as soon as you start to feed them. So you've seen in the NICU that we often will feed early, and this is one of the many reasons that it's helpful, is that it'll keep the gallbladder motility up to prevent stones from forming. So also, ceftriaxone can lead to what are called pseudoliths. These are not true stones like you would see with pigment. They're more like calcifications from the ceftriaxone, which is precipitates in solution. These are, as a majority, resolve and self-limited. Interestingly, in one group, just children who were being treated for bacterial meningitis, almost nearly half developed stones in there. And then an interesting thing is that Gilbert's, trisomy 21 people also have risk for gallstones, and then Gilbert's. So going back to this, Gilbert's is a problem with our conjugation from UDP glucuron transferase. The gene is UGT1A1, and it's very common in the population. Roughly 7 to 9% of the population has Gilbert's. But there's an increased risk for gallstone disease in these patients. So this is a small series of children, actually, looking at if they had the gene for Gilbert's, which is a TA repeat in the promoter for the gene. So if you if you're homozygous for it, you can see that you have almost a 2 to 3-fold increased risk of cholelithiasis compared to those who are just control population. This is less, so this is the normal state. You can see the majority of these people did not have cholelithiasis in this group. So in a larger group out of India, they showed that they had 1,200 patients almost who had cholecystectomies, and 106 of those patients had Gilbert's. That's roughly 9%. According to the National Organization of Rare Diseases, 3 to 7% of the population has Gilbert's. I think I said 9. I was getting confused with this. So this was higher than expected amount of gallstones than for this population. So how does this help us? So if you have a patient that has Gilbert's, it's good to know, because you might be prone to do extra studies on somebody who has jaundice, and it might be just their Gilbert's syndrome and not any kind of common duct stone causing cholestasis from that or obstruction. Now, if you have hemolysis and you have problems with conjugating, that's going to enhance your risk of having even more unconjugated bilirubin coming out to precipitate. So brown stones are those mixed stones. They're in between. They have more, they have less calcium, less bilirubin, and more fat, more cholesterol in them. And these are universally seen with bacteria or parasites. So if you were practicing in a country that had ascaris, they like to climb up into the is anybody eating? So it climbs up into the biliary system and obstructs that flow. And then there are bacteria that can contain these enzymes, and these deconjugate the bilirubin, making you more at risk. And after you take your gallbladder out, you can actually have recurrence if you still have this problem. So calcium carbonate, just mentioned this. This is not seen in adults. It's precipitation of mostly calcium carbonate. It sticks to the mucin that's in the wall of the gallbladder, and these stones are largely radiopaque. And this picture is just to show you the 3 types. So this is cholesterol, this is the mixed or brown type, and these are the black pigmented stones. And this just shows you their constituents. So you can see in pigmented, there's hardly any cholesterol, more calcium, and then some bilirubin. Whereas if we go all the way to cholesterol, those things are a minority, and it's all cholesterol. And then here in this, the brown stone, you can see a mixed picture. So as we think about children with stones, hemolysis accounts in the past for about 30 to 40% of all cholecystectomies. So a majority, or not a majority, but a predominant number. And this is a series from 2010 looking at children who came for cholecystectomy. And you see that sickle cell disease is a high number of these patients. But then there's none of these risk factors. These are all some of the things that I've talked about for black pigmented stones. So what about this group, this large number here? And so this slide is very important. This illustrates the changing tide of the demographics of gallstone disease in children. It used to be hemolysis, and we didn't do many cholecystectomies. This is from Texas Children's. It's a retrospective study from about 10 years ago. And each line has some interesting things. So first note that this is over almost a 16-year period. They only did 128 cholecystectomies. Then in this 4-year period, they quadrupled the number of cholecystectomies that they did, showing that many more people had gallstones disease in children. We're looking for it more. Ultrasounds are more a part of everything that we do. I mean, how many do we order for everyone who comes in, missing school? So we're starting to detect stones much more. You see the age is a little bit higher, and perhaps it's because the different demographic. It's a little bit more enriched in female. It's more obese, more like the adult risk factors that we saw earlier. Less hemolytic disease. It was 41%. Now it's 19%. And then there's this new player, biliary dyskinesia 0 back in the 80s and 90s. And now we're doing these with a good percentage of time. And formerly it was open, and now almost universally laparoscopic. It's a very interesting slide showing that it used to be more hemolytic disease that was a problem, and now it's something different. And so to get us started to talk about cholesterol gallstones, which is what the change in that dynamic is, let's think a little bit about what's in bile. So you remember bile is what was excreted from the liver, and it has some important constituents that keep everything in solution. There's bile acids, which are important, cholesterol, and phospholipids. If you have enough phospholipid and you have enough bile salts, then it's okay. You can collect enough, you can hide your cholesterol and get it out. But if those things start to drop off, then you'll have more chance of cholesterol precipitating out. Now, you know how you see slides throughout medical school, and there are things that might give you PTSD. So, there's the Embden-Meyerhoff pathway, right? This Krebs cycle, you just kind of go like this. And that's what this slide is. So that's what we're going to with that. So before we get to that PTSD moment, let me talk about how cholesterol is managed and gets out. And this just reviews what I was just talking about. Most of the cholesterol is exogenous. It's what we eat, and it comes to the liver to be dealt with. We either metabolize it and then kick it back out to store, or we get rid of it. And we secrete it across this transporter. And then bile salts are also being excreted through this. So this is a liver cell, in case you didn't know. This is a liver cell, and then this is the calculus lumen here. So you can imagine another liver cell on the other side doing the same thing. So this is taking this wall here and blowing it up. So here are these transporters. So look at these names. So this stands for, the ABC stands for ATP binding cassette, subtype G, 5 and 8. It's also known as sterolin 1 and 2. And so this is what's important for getting cholesterol out. This one here is important for getting phospholipids, which help to solubilize and keep cholesterol in solution. The cholesterol is held in here. And then this gets rid of our bile acids. And each of these, with mutations, causes disease. So as I was showing you, this triangle, which you might remember from medical school, shows you how if you have less phospholipids and more cholesterol, so in this region, you're more prone to having cholesterol precipitate. And if you look here, there's different phases. If you're in here, you just have micelles from all the increased bile salts. They can capture and solubilize the cholesterol. But if you have both bile salts and phospholipids, your chance of keeping the cholesterol in solution is much better. So it'll travel with the phosphatidylcholine, phospholipids, and then it will stay in solution. But if you have decreased phosphatidylcholine, you can have precipitation, and there's actually some diseases. So that one receptor I told you about, if you have mutations in that, it's responsible for progressive familial intrahepatic cholestasis, but also intrahepatic cholestasis of pregnancy. Not all the cases, but some. And then people who are just prone to stones, something called low phospholipid-associated cholelithiasis. So the people that are prone, that are in the family that get stones, this is most likely the problem, is that one transporter, which is this one here. And this just shows you these mixed micelles and how we get bile salts and cholesterol out. And these things have to all be working well. If you have mutations in this gene, you excrete too much cholesterol, and those people also are prone to stones. So what are the conditions that predispose us to cholesterol stones? Remember our adult group, and some of the same risk factors are true in children, so obesity, gender, and age. And so this is that same Texas Children's article, just portrayed a little differently. And what you see is that with increasing age, the incidence of cholecystectomies went way up. And also, this is showing you that obesity is also a problem. So this is BMI greater than 25, that almost 70% of the cases of cholecystectomy were done in this population. This is another series of 4,200 ultrasounds showing that with increasing age and also with female gender, that there's an increased incidence of gallstones. So cystic fibrosis is also a problem, as I mentioned earlier, and in one autopsy study, almost a quarter of patients had a hypoplastic gallbladder, sometimes even absent, and the bile is supersaturated with cholesterol. We mentioned ileoresection as something that was prone to pigmented stones, but also if you cannot reabsorb bile acids, remember bile acids help us to solubilize cholesterol, then you're more at risk for gallstones. In trisomy 21, patients, there's an increased risk in patients with trisomy 21, partly because their gallbladders are smaller and they don't contract as well. as their peers. And these are just some of the genetics I was mentioning, these transporters. And so this is a summary slide showing all these risk factors for childhood cholelithiasis. It's kind of sort of something to take away from the talk is, who are the patients that I need to worry about? So these are these hemolytic problems, but also increasing age, increased female gender, and then increased weight. It's something to consider as we see our increasing population of people who are obese. So how do the stones present? So in a good half, most will be asymptomatic. And these people, if you incidentally find a stone on an ultrasound, you should be able to counsel them that we're going to watch this in time. You certainly don't want to ignore them if they start to have pain, but these people can be watched with some success. Only a rare frequency will have symptomatic gallstones. And what are those symptoms? Usually the pain is distinct from like irritable bowel. So irritable bowel, is pain that's sort of generalized, more vague, usually is with meals, usually lasts 30 minutes. Often will make you go to the bathroom, the old eat, pain, poop sequence. So so in biliary colic, it's a little bit different. So we eat, and then we have pain that's pretty severe, lasts hours. Majority is in the right upper quadrant, but it could be epigastric. It might radiate to your right shoulder and back because of referred pain. And then in distinction to people who have appendicitis, who don't want to move because they have peritoneal signs, these people are more restless. They can't get comfortable. Other signs might be fever, jaundice and pain. That's a Charcot's triad. And usually that indicates that there's a stone perhaps there or was in the common bile duct. If you have hemolytic disease, you might be more nonspecific, more like your IBS pain, and you might miss that person. Nausea and vomiting are present, and also a Murphy sign. So how do we find out someone has gallstone disease? You can do an X-ray, which is not really, usually might pick up on it. You remember, half of those people who had black stones, black pigment stones, will be seen on X-ray. You've already seen a porcelain gallbladder, you might see that on an X-ray. But the rest of the stones are going to be lucent. You're not going to see that on plain film. So ultrasound is really the go-to, the gold standard, so to speak, for finding. And this slide, which I borrowed from the internet, is helpful in showing you these features. So what you see here is the gallbladder, and this gallbladder has a thickened bowel wall. You're also looking for pericholecystic fluid, which isn't seen as much here, but that's an evidence of inflammation. Here's the bile, and then you see this sludge. We're going to talk a little bit about sludge in a bit. Then this stone, and the notable thing about stones is that they show shadow underneath of it. That's when you know that something is there. If you rotate the patient, they often will slide back and forth with them. Very sensitive, and you can see stones down to as small as 1 to 3 millimeters. So other uses for ultrasound are to try to look at the common duct. It's important if you get a report back, because they might not always tell you this, hey, worry about this. What size common duct do I worry about? If it is their dilation, often when a stone passes, it'll still stay dilated. So if you can say 6 to 7 in your mind, anything bigger than that in your mind, you should be thinking this is probably abnormal. And as I mentioned, wall thickness is key. So if there's wall thickness, there's evidence of inflammation, sludge, pericholecystic fluid. And it also can be used after a fatty meal to show that it hasn't contracted. So if it doesn't contract, it means it's not getting that bile out. Other modalities could be CT. This could help you to see other complications like pseudocysts, pancreatitis. MRCP is used for looking at if a patient has common duct stones. And then a HIDA scan. That's just what that HIDA stands for. So a HIDA scan is may be helpful with cholecystitis only in that you give them the radionuclide. It's supposed to home to the liver, be secreted, and then get stored in the gallbladder. But if it can't get into the gallbladder, you don't see it being stored in the gallbladder, then that's a sign that maybe there's obstruction there. It's also useful in biliary dyskinesia, which we'll get to. So how do we treat patients with gallstones? So you might consider, is there a non-surgical way to deal with this? Can I give a medication to help with this? And so ursodeoxycholic acid, or actigal, has been proposed as a possible measure. This increases your bile salt fraction, and so you have more solubility of cholesterol stones and cholesterol crystals. And it really doesn't take the stones away. It helps prevent them from worsening. And once you take them off the urso, their problem comes right back. So it's not really used with any degree of frequency. Statins are intriguing because they decrease cholesterol secretion, but not really something that we use a lot. So surgical treatment is really the answer. Putting a hole in the gallbladder and draining it to get the stones out is a thought, but usually the stones come back and you really haven't solved the problem. So cholecystectomy is the gold standard. It's very safe in children. They usually use 4 trocars, but some are advocating for one alone in the belly button. And the complications are usually seen with people who have only done 1 or 2 of them. Once you've gotten 15 under your belt, the chances of you ligating the common duct versus the cystic is much less. Retaining a common duct stone is also very much a complication or a worry, and we'll talk about that in a second. So when should you do the surgery? So typically it's when the patient is sick in the hospital and they've cooled down, that would be the time to do it. But if it's an incidental finding, then you might want to either wait if it's asymptomatic, or if it's hemolysis, set them up for elective surgery. So this is a series looking at pancreatitis. These are patients who came to the hospital and were found to have gallstone pancreatitis. And what their outcome was if we waited and sent them home versus doing them during that hospitalization. So, what this table shows you is index admission means during that hospitalization. So 0 of 19 developed future pancreatitis because they didn't have the chance to. And so none of these people had complications. What you see is at the longer that you go, the increased percentage of chance that you're going to have a complication and be back in the hospital. So if you can, and you guys have seen this, the surgeons would like to get these done during that procedure, but they'd like to see the pancreatitis getting under control. So common duct stone is seen with some frequency, 7 to 20%. You usually will have increased pain, fever, Charcot's triad again, increased ALT, bilirubin, alk-phos, GGT elevation, and you might want to get an MRCP if those features are not improving. Pain's not getting better, the labs are not improving. And so how do we take care of that? There's several different ways to do that. You can actually just send them to the OR. They can do a cholangiogram or try to find the common duct and see if that stone is still there, and then explore the bile ducts. Not really favored by the surgeons. It increases your risk of complications, so they like to avoid that. So if we have strong evidence that there's a stone from maybe MRCP in the labs still persisting, then sending them to an interventional gastroenterologist to have that done is helpful. Or if you see it, you didn't get it out during the procedure, then you still have time to do one afterward. Now, if you practice in a place that doesn't have an interventional person, then you might have to rely on your surgeons to manage that. They might be more prone to handle that. And now there was a paper that came out in our journal in a last month or so talking about this laparoscopic endoscopy rendezvous where the surgeon threads a wire through the gallbladder into the cystic duct into the main duct, and then the endoscopist grabs it, and you can maintain connection. They can thread the channel up and pull the stone out with a balloon. So what do we do about sludge? So now we're going to talk about some special situations, special populations, and head scratchers that we think about. So what is sludge? It's just crystals in solution and with mucin and cholesterol, and it's mobile on ultrasound. So if you look at sludge, one series looked at sludge in about 35 patients, and 15 of these had no sludge 14 days after seeing it. These are people that they were following with ultrasound. 4 of those, it resolved in just 6 days. So in 26 patients who they followed after detecting the sludge, so I'm sorry, these people didn't have sludge 14 days prior to finding it and then had it. So it shows you that there could be quick onset and then quick outset. So in less than 14 days, about a third resolved, and after with long-term follow-up, almost all resolved. So sludge really isn't an indication for further, you wouldn't want to send that person to surgery necessarily. So what about asymptomatic patients? So these people also, as I mentioned earlier, rarely progress. And this is a series of 194 patients who were asymptomatic, and only 9 of the 194 went on to have problems. And this is 6 had common duct stones, 2 had pancreatitis, and 1 with cholecystitis. Not 0, so certainly something to note. But compared to symptomatic patients who had almost a 30% increase in progression of complications. This is a slide looking at different risk factors for gallstones, showing you that the white are those who are asymptomatic, and the dark bars are those who are symptomatic. So you can see that sickle cell increased risk of symptoms, and some of these others much less so. What about infants? So this is that same article series looking at gallstones through the ages. And so you can see, similar to our earlier graphs, that with time there's increased incidence. But look at this spike. Almost 15% of the total were infants. And so 81% of these were asymptomatic. Only 5 had complications, and all but 1 were watched, and they all resolved. So 41 had follow-up ultrasound, and a third of them had absence of gallstones at that point. Still some had progression, but no symptoms. It's something you can watch. So babies who you see, maybe they've been on TPN, these are your neck children who've lost their ileum, and they're on TPN, you may see gallstones. And these are people you can just follow in time. So here are the risk factors for infants, as I just sort of let the cat out of the bag. So this is TPN, short gut syndrome, TPN alone, diabetic cephalosporins, as I talked about earlier, trisomy, cardiac surgery, and the like. So, so that's it for stones. So what happens if you're inflamed and you don't have stones? What is that called? That's acute acalculous cholecystitis. And this is when the gallbladder just can't squeeze or get the fluid out. It gets under stasis, it can get inflamed. This is also the setting when there's ischemia. Remember the cystic artery coming to the gallbladder. If there's ischemia to the gallbladder, then it can cause inflammation. It's a minority of adult cases, but look how many we see in children. And we've seen these people in the ward that come in for something, and we'll go over their risk factors and what it might look like. So there's this little nomenclature thing that I wanted to go over. And as you're going through the literature, you get kind of confused. There's high drops of the gallbladder, and then there's acute acalculous cholecystitis. Are they different, or are they the same thing? Are they just part and parcel of the same thing? So if you go and look through what are the definitions for each, okay, so high drops is distension of the gallbladder without the presence of calculi. What is this? Oh, distension of the gallbladder without the presence of calculi. Okay, that's helpful. So then these have wall thickening greater than 3.5 centimeters. Oh, wall thickening greater than 3.5 centimeters. These are typically resolved without intervention, but these have a high inflammatory component. They're sicker, and sometimes there's mortality associated with it. So how do we differentiate these? You see that high drops seen more with these disorders. If you go in the literature, you're going to see these lumped under here, and you're going to see some of these lumped under here, and so it's very difficult to tease this out. So just know that when you're reading about these things, they could be part and parcel of the same thing. But just think high drops is more benign, maybe less thickening on the gallbladder wall. So there's one paper about 4 years ago proposed that we just break these people all down into the same group of acute acalculous cholecystitis and break them into 3 groups. And one is people that are sick with critical medical conditions. They come into the hospital, they're septic, they just had surgery, they're burns. What happens is there's ischemia, there's lack of motility to the gallbladder, there's stasis, bacteria forms in there, the bacteria invade the wall that they can become septic. And so it's like an abscess sitting there. So to some extent, the pressure is there to drain that or do something to it. And do we do that? Well, back some time ago, that was the case. Or more, what we see There's children who have non-medical, non-critical medical conditions like lupus or frequently Kawasaki's disease, malignancies, CF, and even with COVID, we've seen a couple of cases with acalculous cholecystitis with MIC syndrome, or MIC. So Kawasaki's, interestingly, just as a side note with that, if you, some have suggested that if you have hydrops of the gallbladder with Kawasaki, that you're more apt to have coronary artery disease with it as well. So patients who were previously well then would be someone who just gets like a viral infection and you come in and you notice while they're jaundice or they have some liver lab elevation, so they buy themselves an ultrasound and you see this really dilated gallbladder. You know, what are we up against? Well, interestingly, 24 out of 94 patients who had EBV in this one series out of Korea had ultrasound findings. The hepatitis A is another virus. Some other bacteria have been associated with this. These are healthy children who get sick, come in and have this, and they universally will resolve. But when they get lumped in with this other group, you're thinking, oh wow, we gotta watch this kid. We're gonna have to do surgery, you know, because if you read the literature, it's telling you, oh, these people go to the operating room, and let's put some brakes on that. So, and think about it a little bit. So with acalculous cholecystitis, you might have, again, Charcot's triad, you might have elevated inflammatory markers, and then you have an abnormal ultrasound. And these are the criteria for it. So you have wall thickness greater than 3.5 millimeters. That's what this is here. You can see this kind of ultrasound. This is actually a patient that had Salmonella typhi. So typhi is actually associated with acalculous cholecystitis. We don't see that much in America, but so you can see the thickening of the bowel. You can see it's a little bit distended. Maybe that's a little bit of sludge in there. And then paracholocystic fluid would be surrounding it. So how do we manage it? And this is where that differentiation between the two groups is important. Back in times that I know about, not many of you here, but in the 70s through 90s, papers would argue for operative drainage or to take the gallbladder out. And certainly there's some morbidity, but is that what we really want to do with these patients? And more people are saying, let's just watch. Let's watch these people. In one series, this is supported with 131 patients who came in to the hospital, had acalculous cholecystitis, and they had only 2 that needed operative management. No deaths. It indicates that these people are perhaps not the best surgical candidates. We should just watch them, perhaps with serial ultrasounds. And so you can support them with TPN, put them on bowel rest, fluids, antibiotics, pain management, and you want to avoid opiates because that's going to affect that contractility of the gallbladder. And then serial ultrasounds perhaps until they resolve. Okay, so that's acute acalculous cholecystitis, and we're running on the last lap. So this is more of everyone's speed. This is what you see regularly. 15-year-old girl adopted from, this is close to a true story, 15-year-old adoptive girl from Guatemala with recurrent right upper quadrant pain. Her hepatic labs are normal. Ooh, she's not nausea. She has no nausea. She has nausea but no vomiting. Her pain sometimes does migrate away from the right upper quadrant. Her ultrasound's negative, nothing wrong with it. No wall thickening, nothing wrong. So an EGD was done because it was epigastric right upper side to make sure nothing else was there. That was normal. A HIDA was performed, and it showed that there was reproducible pain when cholecystokinin was given. Remember, cholecystokinin is the hormone that causes gallbladder to contract, and they had an ejection fraction, that's what EF is, of 20%. So she was referred to surgery because it met criteria for biliary dyskinesia, and she had an elective laparoscopic cholecystectomy. She improved, she felt better for about 3 months. And then she was back in my office. Pain, nausea, occasional vomiting, right upper quadrant, generalized pain, and then it started to migrate different places. So was that IBS that I just sent to the OR? So that's why I wanted to talk a lot. This is what kind of led me to want to do this topic, is this happens so regularly for us, is biliary dyskinesia. So the symptoms are not always clear. They have the same kind of right upper quadrant, might be epigastric pain, more vague. They might have right shoulder pain, and then you don't see any other causes. And as I was mentioning with your patient, you diagnose it by a HIDA scan. At 35% ejection fraction or less, is diagnostic. The pain is reproducible with cholecystitis. That's also a helps just another finger on the scale. It kind of tips you over to want to send them to surgery. So how do they do? So my patient that I just mentioned didn't have long-standing success. So if you read literature, you're going to get everything. So many say, hey, this is great. 77% get better, but there's still a good quarter that aren't better after this. In the pathology, interestingly, the majority of these are abnormal. So there's actually does show cholecystitis there. But what about the bad? What about bad outcomes? Sometimes the long-term outcomes are inconsistent. One systematic review looking at multiple numbers of series showed that really ranges from anywhere to 100% people getting better to even just as low as a third getting better. So are there ways that we can predict who's going to do better and who we should send? Like who we should do a HIDA scan on, who we should send so they have a better outcome. So all these factors were looked at in one series. So right upper quadrant pain, nausea, postprandial pain, constipation, and then they had their diagnostic features of the HIDA scan. And they those were in this one paper, but interestingly, there's usually no control in these. So you're not, this is just a series showing if I took 10 of us and we did something, if you had something you felt was wrong and I sent you to a surgeon and you might mentally think you're doing better. So there's no control in this. So two studies actually make you doubt the success of this. So this is looking at 55 children actually who had cholecystectomy, and 35 of the 55 total had biliary dyskinesia, who went on to have cholecystectomy. And a good 3/4 again improved, just like the other study. However, in 2 years, 3/4 of the control group got better as well. So could we just watch them and not put a hole in them? And they would have gotten better in time. And in this study, only weight loss was predictive of response to surgery. In another sort of concerning study, 42 children were looked at. So 25 had cholecystectomy, 17 were just observed. And in the short term, the majority got better who had cholecystectomy. But then long term, roles flipped. The people who had surgery actually were not doing so well anymore. So what do we do? So, and then there's this other group, biliary hyperkinesia. So just in case it's too normal. So these are people who have an ejection fraction greater than 80%. And one paper collected, it was, I think, 3-4 centers, collected 18 patients and showed that the majority of them got better, and they also had abnormal pathology, but like I mentioned earlier, no control. So these are just my suggestions based on that sort of conflicting data. So certainly we don't want to stand in the way of somebody who's going to get better after having this procedure. So I think if it smells and acts and walks like gallbladder, you're thinking it's gallbladder, then you do your HIDA, and you might have more of a chance of that going away. But let's think about other things first. Is this IBS? Should we manage their IBS? Do they have gastritis? Should we have a scope done? Should we look for other things? Do they have celiac disease? So try to be very broad in our evaluation before we send them to the HIDA scan. Because once you send them to the HIDA scan, you're committed. Because what are you going to do if the ejection fraction comes back and it's low? That patient's always going to think, why is my doctor standing in between me and the solution? You know, I want that. I'm tired of feeling this way. So that's it. So let me just so far for the week. So remembering the kinds of people who are prone to having gallstone disease helps us to know like what age brackets, what we're dealing with. A 9-year-old who has right upper quadrant pain, that patient's probably has some other predisposing factor. They're not going to have like cholesterol gallstones like you would see in a 16-year-old girl, perhaps. So the more, the cholesterol stones are now more the majority than they used to be. And then, as I mentioned, different groups to what. Gilbert's is common. It may predispose to pigment stones. It might be something you might want to tell your patients as they age to think about that. A 4-fold increase for Gilbert's. By the way, I looked up Gilbert's to know how to pronounce it because I've heard people say Gilbert's and I've heard people say other things, and it's from a French dude, so it's Gilbert. So Anyway, hemolytic conditions warrant operative management when you diagnose it. Children with biliary colic, they present distinctly different from IBS and other etiologies of pain. Ultrasound is the most sensitive and safe way of making a diagnosis. There's not a role for medical therapy except for a few exceptions. Symptomatic stones should be sent to the OR, usually managed during the index case admission. And acalculous cholecystitis can be serious, but for the most part can be watched. And as we have to follow up the serial ultrasounds in supporting the patient. Okay? So should I ask questions first, or should we go through our multiple? Okay, let's do that, and then we'll ask questions. So these are, question one, these are pretty easy. Aren't you glad you should get me to write questions for tests? So which groups of patients with gallstones can be watched? Y'all want to yell it out? So,
C.
C. What? C and B?
D.
C and D. And E. So Cordle and TPN also. So remember pancreatitis, remember increased incidence, even if you release them from the hospital, and then hemolytic disease, if they're symptomatic, you want to take that out. So the following conditions predisposed to gallstones except, this is only one of them. This might be a little tricky. Which one? So remember, so Crohn's is ileal, so they're going to malabsorb bile salts, and you're going to have more absorption of bilirubin, so you're going to be more prone to having stones. Cystic fibrosis, remember those were seen on autopsy, many more. C, Kawasaki's is seen with acalculous cholecystitis. TPN, sickle cell disease, pregnancy, all seen with cholesterol stones, so it's Kawasaki's. Tricky. So, one more. So the Phrygian cap is named after the cap worn by Jacques Cousteau, Starbucks baristas. Or sort of the reverse, right? The reverse Phrygian cap. Smurfette. Revolutionary War soldiers or Spartan warriors. See. It's actually really from a region in present-day Turkey. Phrygia, Asia Minor, in the past. All right, any questions? I think we have 1 minute or two, or am I supposed to turn into a puppy? Anything that anybody or online?
A quick question. Excuse my ignorance, but so if we have these common patients, a 16-year-old obese young lady comes in with textbook symptoms, looks like it may be choledocholithiasis, they have an element of pancreatitis, and we, of course, we're waiting for everything to calm down. The surgeons are going to likely do what they do and take the gallbladder out. Where in that whole thing, especially if you have ultrasound-proven disease, does like an MRCP come into play, and how is that helpful for these patients?
Yes, so good. I'm glad you brought that up, because I think I went through that kind of quickly. But so you would start to be following liver enzymes, and if they're still having Charcot's triad, so if they're still febrile or they're having, they don't have to be febrile, but if they're still having that, still jaundiced, still not unremitting pain, so clinical symptoms not improving, then you might have an ongoing common bile duct stone. That's what you're asking about.
Yeah. Okay.
When to do an MRCP to look for that. So that group, so symptoms. Then number two, enzymes. So you're going to track their ALT, their GGT, alk phos, bilirubin. You're going to see, even without common duct stone, I didn't mention this, but a good half are going to have elevation of those enzymes, even without a common duct stone. So that'll trickle off. Their pain and everything will get better. Those numbers start to improve day by day. So you'll see the surgeons usually say, or us will say, trend these factors, and we'll watch in time. Unless the pain is unremitting, unless it's severe, then you're going to probably send them. You might send them straight to ERCP, but MRCP helps them to feel more confident to go down that pathway and try to get that stone out.
Gotcha. So mostly unremitting symptoms. If they're improving clinically, if they're improving clinically and their labs are improving clinically, and we know what it is, and it looks like it's passed for now, then we don't necessarily need that study. More likely need the surgery procedure when they calm down. Got it.
That's right.
Okay.
Yes, ma'am.
Forgive me if this is a stupid question, but is there any specific link with fatty liver disease and the enzymes and gallstones?
Only in that they share risk factor groups. So that's a good question, actually, because It's not been shown necessarily, but people who have fatty liver, I think, can also have right upper quadrant pain. I've seen, just based on perhaps the hepatomegaly, maybe stretch of Glisson's capsule and some pain in that. And I don't know if I'm making that up or if that's a true pain thing. But they also are going to have some mild elevation of their liver enzymes, too, it's going to be confounding. They are going to be insulin resistant. They're often going to have trunk oil obesity if they have fatty liver disease. And so that population is enriched in those who have also cholesterol stones. So yes, so person who has those risk factors has known fatty liver disease. You might, and they have a sudden spike in symptoms or spike in pain, you might want to reevaluate with an ultrasound. Does that answer that?
Yes, thank you.
Okay. Anything else? Okay.
Thank you so much.
Thank
Dr.
you.
Cordle.